Hello, welcome to the webinar. Thank you so much for attending this webinar on Prevent Child Injury. We are so pleased with the interest in this subject, and I must say that we have people registered from British Columbia to Newfoundland, and so a big welcome to each and every one of you. Slide 2. Just to quickly go over the goals for today's session, we want to describe the research findings and subsequent development of a messaging strategy for the prevention of child injury, and to start the discussion for implementation of this strategy. Slide 3. I want to give special thanks to the funders for this phase of our project, Public Health Ontario and Ontario Neurotrauma Foundation. And thank you to the Ontario Injury Prevention Resource Centre and Oxford County Public Health for their technical support for this webinar. Slide 4. Injuries are defined as all the ways an individual can be physically hurt, impaired, or killed, involving intentional or unintentional damage to the body. Injuries can be intentional or unintentional depending on the intent to cause harm. Intentional injuries include actions such as self-harm, suicide, assault, homicide, and abuse. Unintentional injuries can include falls, poisoning, burns, scalds, motor vehicle crashes, or drowning. The project we will be presenting today focuses on unintentional injury. Injuries occur in young children as they develop and explore their surroundings. Their bones, muscles, vision, and balance are still developing. They are learning new skills all the time and don't have the risk management skills that adults have to judge whether or not their activities are safe. Slide 5. Falls and burns and poisonings account for the 3 most common injuries. Most common preventable childhood injuries in Canada and in Ontario, and are the leading causes of hospitalization in those 0 to 48 months. For example, children can fall from change tables, cribs, furniture, or down a flight of stairs. Scalds and burns can happen from spilled coffee or tea, bath water that is too hot, or hot foods. Children can be poisoned by prescription or over-the-counter medication, vitamins, cleaning supplies, hand sanitizer, or makeup. Slide 7. Sorry, I skipped a slide. Just to give you a brief background of this project. In 2007, Ontario Injury Prevention Practitioners Network was formed to enhance collaborative opportunities for injury prevention throughout Ontario. I'll call this organization OIPEN. OIPEN members represent a variety of backgrounds and multidisciplinary membership, including enforcement agencies, public health units, trauma hospitals, NGOs, and government. There are multiple types of injuries that impact all ages across the lifespan. In order to maximize OIPEN's existing capacity, they recognize the need to determine injury priorities. It was decided to adopt a validated injury priority setting exercise developed by the Winnipeg Regional Health Authority. Following the injury priority setting exercise in 2009, that included the consideration of both quantitative and qualitative injury data. Injury prevention priorities for OIPEN were determined. Subsequently, 2 subcommittees were formed: prevention of motor vehicle injuries in the 16 to 24-year group and prevention of falls in children 0 to 4. The Prevention of Falls Committee discovered that very little research had been done around the prevention of falls in children 0 to 4, and very little in the way of best or promising practices. One program that appeared to have some impact was A Million Messages from Alberta. In 2006, Safe Kids Canada documented A Million Messages as a promising practice in their resource, Safer Homes for Children, A Guide for Communities. In 2008, the Ontario Neurotrauma Foundation developed the document Science and Sustainability in the Prevention of Neurotrauma. The document highlighted the best practice elements of A Million Messages and its potential application in Ontario. This was followed by the release of their A Million Messages Implementation Guide in October, highlighting key elements for adapting the program. A Million Messages provides staff with the tools to integrate simple, consistent, routine, and age-appropriate injury prevention messages into core business. The concept of repeated targeting messaging was clearly identified in the literature as a successful strategy in increasing awareness, ultimately leading to behavior change. As gaps were identified, new resources were developed. A consistent injury prevention family graphic was created, and this branded design is used on all safety-related resources or displays produced by Alberta Health Services. From this work evolved a program which became known as A Million Messages. A Million Messages branded resources include resources and displays, and also checklists, as well as a variety of verbal key messages, pamphlets, rack cards, and posters that target a wide variety of topics pertinent to various ages and developmental groups across the lifespan. In Alberta, all immunization is administered by public health staff. This gives the opportunity to give consistent, developmentally relevant injury prevention messaging. This is not the case in Ontario. Thus, there was quite a bit of discussion on how we can adapt A Million Messages to be effectively used in Ontario. In April 2011, the provincial A Million Messages Steering Committee was formed. Members consisted of a variety of stakeholders, including researchers, OIPN, Managers Alliance, public health practitioners, NGOs, government, and hospitals. In 2012, the Ontario Child Injury Prevention Committee applied for research funding through Public Health Ontario's locally driven collaborative project initiative. Before I go any further, I do want to say that there are those involved in the project recognize that the importance of play, and we're now on slide 8. Play is an important part of early child development. Through play, children develop their fine and gross motor skills, language skills through interactions, social and emotional skills. The aim of promoting child safety is not to reduce children's physical activity or to prevent them from exploring their environment due to the fear of them getting hurt. Therefore, injury prevention efforts are focused on recognizing and reducing the risk for serious injuries due to falls, burns and scalds, and poisoning, so the child can be kept safe during play or at any other situation. It is not to restrict their movements or to reduce their playtime. Slide 9. The locally driven collaborative project was a large-scale qualitative investigation examining the facilitators and barriers to implement key components of a messaging strategy. Slide 10. The co-leads for the project were Christina Bradley from Niagara Region Public Health and Casey Walters-Gray from Kingston, Frontenac, Lennox, and Addington Public Health. And the key researcher was Diane Mack from Brock University. And special thanks to our funders, Public Health Ontario and the Neurotrauma Foundation. Slide 11. Here is a list of the whole LDCP team that worked with Christina and Casey and Diane Mack for the development of this whole project. Slide 12. This 2-year study included qualitative data collection in the first year and pilot testing of the messages in the second year. Slide 13. The focus groups and key informant interviews were conducted in 4 different catchment areas: Kingston, Frontenac, Lennox, and Addington, Niagara region, Thunder Bay, and York region. Slide 14. Focus groups were conducted with community stakeholders. Participants who self-identified as interacting with parent caregivers of children ranging in age between 0 and 4 years represented 19 different occupations, with early childhood educators numbering 13 and public health nurses numbering 12, and they were the most highly represented. Participants were asked to give their insight on types of injuries experienced in their present occupation, injury prevention, their roles, barriers, and facilitators, and injury prevention messaging. Participants divided the types of injuries to those that a mobile child could initiate versus those experienced by younger children, babies, who are not independently mobile. There was considerable discussion about the preventability of injuries. The most common types of injuries are bumps and bruises during play and are seen as inevitable by most participants, although several felt that any injury is in fact preventable. Injuries deemed most serious were believed to be preventable, with burns and skulls being the most common. For children who are not old enough to be mobile, falls, such as rolling off a surface, choking, and burns were most commonly seen. All participants felt that these types of injuries were always preventable and resulted from behavior by parents or caregivers. Analysis showed that preventable injuries could be grouped into different broad themes. The first centered on parental supervision, and the second focused on the structural prevention in the built environment. Many participants deal with safety on a more voluntary level when the opportunity arises or if they see something and the timing is right. But many admit that until participating in the focus group, they had not really considered incorporating safety as a part of their central role. All participants noted they have professional responsibility to ensure the safety of children. However, some saw injury prevention as their number one role, while others suggested it was an add-on to their responsibilities. Although the role of the participants varied widely, they all stated that it is ultimately the parent's choice as to how much they engage in safe behaviors. The key factor to any delivery is the timing, that given a situation, often the timing is not right to address the issue. Participants felt that the ideal educational approach is face-to-face discussion with parents. Written materials in the form of pamphlets were generally regarded as all but useless in changing parenting behaviors. They felt the checklists were more viable as they involved an interactive component and could involve children. They felt that media campaigns were most successful if a single message is consistently and repeatedly communicated. They felt that current videos were silly, often using out-of-date evidence and poor messaging strategies. And if using videos, YouTube videos were inexpensive to make and can easily be updated. Social media and technology were identified as one of the most effective ways of engaging parents and even young children, although they were not without their challenges. Slide 15. Key informant interviews were conducted. Of the 26 interviewed, 23 were female and included 9 physicians, 6 nurse practitioners, 3 registered nurses, plus other aligned professions, including public health nurse and early years supervisor. They felt that practically a parent cannot prevent all injuries from occurring. Rather, the focus should be on raising awareness of growth and development and subsequent risk management. Both parental supervision and structural prevention were clear emerging themes. Both the focus groups and key informants identified similar barriers to giving injury prevention education. These included their role with the parent, competing interests and priorities, parental barriers including their priorities, fear of stigmatization and defensiveness, and environmental barriers including literacy and language, education, multiple children, and other social issues such as drug and alcohol abuse. Participants clearly stated the benefit of standardized structured age and stage-based message delivery through sources such as the Rourke or Nipissing developmental screens. They spoke of the benefit of providing additional resources to the parent to back up the message. Their concerns were that there are no specific written resources developed for targeted age ranges, information overload for parents, out-of-date materials, and conflicting evidence, and finding credible evidence on the Internet. They recommended that written materials be developed that were age and stage appropriate, and the use of technology and electronic messaging should also be explored. Slide 16. Lastly, public health staff with an injury prevention focus were interviewed. Participants stressed that public health must work with community partners, that public health does not work in isolation. They need to work with community partners to identify common goals and approach to child injury prevention. It is easier when public health and community stakeholders are invested and interested. It was noted that in some public health units and with some of the community stakeholders, childhood injury prevention was not perceived to be of primary importance, and other topics such as SIDS often were given higher priority. Participants clearly expressed the need for management both with public health and community stakeholders to support and invest in childhood injury prevention. Uniformly, the participants felt that a provincially consistent messaging strategy was needed. This campaign would be consistent across the province and simple in its messaging. The added challenge was that participants expressed the desire that it be adaptable so that each health unit could tailor the messaging to the specific concerns and needs of their communities. The idea of a childhood injury prevention working group was consistently identified in an effort to collaborate and support one another in this important initiative. Slide 17. In summary, we learned that there are competing priorities. Community stakeholders, both health and non-health, can deliver childhood injury prevention education, and that registered early childhood educators are well positioned to do that. We learned that there was a need for consistent, standardized approach for all stakeholders, and there is a need for enhanced ease of access to the messaging for both stakeholders and parents. Slide 18. We also learned that ideal delivery includes both in-person contact and technology, that the messages are timely and tailored to age and stage of development, that consistent messaging is repeated by all stakeholders, and that the messages communicate doable actions, that parents can easily make small changes that can make a big difference. Slide 19. Using the information obtained from the focus groups and interviews, a messaging strategy was developed. Slide 20. So we have what, so what, now what. Personally, I think that this framework, what, so what, now what, is the most significant outcome of the whole project. Slide 21. What can my child do now? Children are continuously changing and developing new skills. Being able to recognize what they can do based on their stage of development is important when preventing any injury. Therefore, the what question is designed to prompt the parent caregiver to first consider what activities their child can do. For example, they identified that their child is starting to roll around. So what can hurt my child? As their child develops new motor skills, their risk for injuries change. Being able to identify potential dangers allows them to think ahead and assess their home environment for any possible risks that can affect their child in relation to their newly developed skill. Therefore, the so what question is designed to prompt parents and caregivers to explore and identify home hazards. For example, they identify that their child is now at risk for falling from places like change tables and couches because they are starting to roll around. Now what can I do to keep my child safe? After new dangers have been identified, it is now time to develop a plan to keep their child safe. Knowing how to prevent these injuries before they happen is the most important step. Therefore, the now what question is designed to help parents and caregivers find ways to prevent injuries based on the child's skills and risks. For example, since their child is at risk for falls, placing a hand on the child. My apologies. Placing the hand on the child while they are on a high surface, such as a change table, bed, or couch, keeps them from falling off. Slide 22. "39 key injury prevention messages were developed by the Message Evaluation Working Group of the Ontario Child Injury Prevention Committee. This group reviewed popular websites, campaigns, and relevant research to obtain pertinent injury prevention messages linked to falls, burns, and poisonings. Messages that were more general were also examined, as members believed that including these messages were important regardless of age or stage of development. From the scientific literature, evidence for the effectiveness of injury prevention messages was also examined. Message forming strategies were applied to the messages to improve their impact and effectiveness. These strategies included wording the messages positively and ensuring that they were actionable. Slide 23. The messages were then evaluated by health communication experts and parents and caregivers for readability, technical quality of the message, message representation, message relevance, and other characteristics of the message. Slide 24. 3 measures of readability were used. On average, it was determined that the messages were written between a 4th and 7th grade level. The following questions were asked to determine technical quality. Was the message too long? Was the message difficult to read? Was the message clear? Did the message reflect more than one concept? Was the message effective and action-based? Questions asked for other characteristics included: was the question likable? Was the message offensive or unacceptable? Was the message credible? And will the message prompt parents and caregivers to take action? Slide 25. Here is an example of a fall prevention message for the parent of a child that is 0 to 2 months old. And here is one for a child that's 5 to 6 months old for poisoning. Slide 27. The development of the graphics reflected the findings from a study done by Dr. Barbara Morangello from the University of Guelph. Parents were shown graphics from 1 million messages, and then they were shown the same graphics that had been modified to depict more risk and/or consequence and emotion. They were asked, which image works best with the safety message? Why do you think this image works best? And how well does this picture communicate the safety message? How well does this picture communicate a sense that the child is in danger? How emotionally arousing, fear and anxiety, is this picture? And how well does this picture capture your attention? The ratings of danger, emotion, and attention each accounted for a significant proportion of variance for ratings of fit to the safety message for the modified images. By depicting more risk or consequence and expressing appropriate emotions in the children's faces, parents were more emotionally aroused and paid more attention to the modified images, thus demonstrating more risk consequences and having an emotional aspect to the image, and found that it is important to enhance the effectiveness of messages for safety promotion materials targeting parents. Slide 28. An artist was commissioned to do illustrations reflecting the findings from the study. There was a lot of discussion with the LDCP team and requests for revisions before each illustration was approved. They all meet breastfeeding-friendly initiative specifications. Slide 29. 3 different message dissemination methods were pilot tested. 1, registered early childhood educators facilitated a 30-minute workshop with parents of children ages 0 to 36 months. 2, early childhood educators were asked to identify and use teachable moments to communicate injury prevention messages. And 3, the establishment of a website where parents could register to receive email messages at the appropriate age and stage of their child. Slide 30. Early childhood educators volunteered to participate in a 2-hour training session led by public health nurses. This included learning about messaging strategy, how to deliver key child injury prevention messages through a half-hour parent-caregiver workshop and through the use of teachable moments. A facilitator's manual, including 3 training videos and PowerPoint presentation, were developed for these sessions, and these resources are available on the Prevent Child Injury website. After receiving the training, the childhood educators were asked to facilitate a 30-minute workshop with parents of children 0 to 36 months who attended the ECE's facility, such as a daycare or early years center. Slide 31. Following the training, the early childhood educators offered the half-hour workshops for their parents and caregivers. Most of the workshops were delivered to 5 or fewer parents or caregivers. The educators considered the low response to be due to timing because due to study restrictions, these were done in the late spring and summer months, and the perceived relevance by parents. Many parents felt that the information was a review and that they already knew about how to deal with their children's injuries. Slide 32. In the training, early childhood educators were taught to identify teachable moments, times when they can convey an injury prevention message. Here are some examples of teachable moments. When an RCE observes a child demonstrating a new milestone, when a parent or caregiver shares with the childhood educator that they have observed the child demonstrating a new milestone, and when the parent caregiver asks for child safety related questions. Following the training, the early childhood educators said they used teachable moments less than half of the time the opportunity was presented to them, with lack of time being identified. Half of the early childhood educators felt that they discussed injury prevention more with their parents and caregivers following training and workshop delivery. They offered a strong endorsement for the injury prevention messaging strategy, but only 2/3 were willing to continue their participation in the program. Recommendations included targeting high-risk parents and modify the early childhood educator training. Slide 33. The last part of the messaging dissemination pilot was an email messaging system. Parents were invited to go to the Prevent Child Injury website and register to receive email messages at the appropriate age and stage of their child. This would give them reminders of steps they could take to keep their children safer. Parent-caregiver attendance at the 30-minute workshop did not result in registration to the website emailing system. Due to time constraints of the study, there was not adequate time for it to evaluate the email messaging system. However, parents and caregivers did give some feedback on the website and made some recommendations, and the Ontario Child Injury Prevention Committee will consider these as they try to improve the website. Slide 34. This is the registration page for parents to sign up to receive the emails. They are asked for their email and the ages of their children. They are also asked to give their own first name and the first name of their children, and they're welcome to give whatever names they want. Just an alias is fine. They will then receive messages at the appropriate age and stage of each child up to 36 months of age. Slide 35. Here are a couple of examples of the messages that are sent. Each gives injury prevention messages in reference to falls, burns, scalds, and poisoning. The what, so what, now what framework is used for all of these. This is one for a 13-month child. That's slide 36. Here is one for a 16-month-old child. Slide 37. There are a number of resources available that you can use. Resources on the Prevent Child Injury website include the Facilitator's Guide for Early Childhood Educators, training videos, and PowerPoint presentations, and all of the messages that have been developed. There is also a graphic for a magnet that can be produced to give to parents to remind them of what, so what, and now what, and to direct them to the website. Slide 38. Here are some examples of what, so what, now what that can be used to prevent falls, poisonings, and scalds education. You can use this with staff or with parents. So here is if we look at slide 39, is a blank, and people can work through the exercise of filling this in. And going back to slide 38 is showing how that can be filled in. And you can see that it can be used beyond the three main areas of falls, poisonings, and burns and scalds, that other concerns can also be incorporated in this. So here's 39 again, and then slide 40. Here is an example of how one health unit adapted the resources for its own needs. This is included in a package of materials that is given to new parents. And in the upper left corner of this handout is the magnet, so it can be taken off this resource and parents can put it on their fridge. Slide 41. Here is a tabletop display that has been developed, again using the graphics from the website. Slide 42. The Ontario Child Injury Prevention Committee has a microsite on the Ontario Injury Prevention Resource Centre webpage. The microsite has the minutes and terms of reference for the committee and also include reports from the LDCP study and all graphics, both in color and black and white, and they can be downloaded. The recording of this webinar will also be placed on the website, on this microsite. Slide 43. As I had mentioned, all of the graphics in both color and black and white are available for download on the Ontario Child Injury Prevention Committee microsite. So here are some of them, and on slide 44 are the rest. Slide 45. So where do we go from here? The Ontario Child Injury Prevention Committee feels that this messaging strategy can be readily incorporated in your practice with parents of young children. The what, so what, now what framework can be used to help parents look ahead and see what they need to do before an injury occurs. If adopted, it can provide the repeated, consistent messaging the professionals are asking for. It can be adapted and expanded to meet local needs. Everyone who registered for this webinar will also be sent a survey to help us determine our next steps. This will be sent out by the end of June. You will also receive an evaluation for today's webinar, and we urge you to complete both when you receive them. Slide 46, and at this time we invite questions. And I want to thank you very much for attending and wishing all of you all the best in your endeavors to help keep our children safer.